tutafanya kwanza watatu sasa hivi itakuja baada hapa kwa sasa hivi So good afternoon everyone. On behalf of the government of Tanzania, USAID and as well as JHPEIGO, can I take this opportunity to invite you all to our panel. And today you are going to learn about immunization services and how we have been able to support the government of Tanzania with integration of COVID-19 and routine immunization services in the regions whereby currently we are supporting implementation, which are Morogoro, as well as Arusha, Kilimanjaro, Singida, Kagera, and Zanzibar. So we have two governments here, the government of mainland, as well as the government of Zanzibar. And I really want to take this opportunity to acknowledge all the directors and head of units who are here, and you for taking your time to come and listen and learn from the experts. So our panelists are 6, and they are all experts in immunization services. So we thought of pulling in program manager from Zanzibar. Abdul, can you raise your hand? They will introduce themselves when they start speaking. But we also have very strong regional medical officers. So we also considered gender balance. We have one of our very strongest regional medical officers from Kilimanjaro, Dr. Jerry Kanga. Some of you have heard about him, so today you're going to see and hear from him. And then we also have only 3 regional medical officers who are female in Tanzania, and one of them is here, Dr. Victorina. She's leading in Singida, so thank you very much for representing female in Tanzania. And then we also have a very strong immunization officer from Morogoro, named Masumbuko Gembia. He's currently taking his master's in vaccine management in Rwanda, Simfagiri, lakini it's a fact. And then we also have our healthcare provider who traveled all the way from Kagera, Rwamshenyi Health Center. Adela, can you raise your hand? And then we also have community health worker who is very strong, and he lives in Arusha, and he has been doing a lot of work in Maasai community. And we thought his presence will give us opportunity to learn how we penetrate Maasai community. Amevaa vizuri, but ni CHW. David, can you raise your hand? So with that note, welcome. So we are going to have 2 phases. Phase 1, we'll have opening remarks from our big bosses, big shots, from the government of Tanzania mainland, as well as Zanzibar. And my boss is here. Alice, come here in front, yeah? So the first opening remark will be given by our country director from JHPEIGO, Alice Christensen. She's married to a Tanzanian. She's your wifi and shemeji. And her husband is from Dodoma, Mgogo. So she's going to give us some welcoming and word thanks. Karibu, Alice.
Thank you, Mary Rose. Sorry to just be stepping in. I'm very proud to be opening this session. MCGL has been really, I think, a great example of adaptability and innovation and responding to the country needs. When we first received funding, it was the very beginning of the COVID pandemic, and we were able to really rapidly address the government priorities and directly help with the scale up of COVID-19 vaccine, saving many, many lives. And then we kind of continued that support to help increase and scale up, achieving really amazing results. And then in this phase 3, we've been able to continue to address what the country's priorities are and what the country needs, with looking at how to integrate and address some of the impacts, the negative impacts that we saw with COVID-19. And the way we did this is really why I'm up here today, is to really acknowledge and thank all of our partners in this road, this long road to where we are today. So first and foremost, I would like to thank the governments of Tanzania and Zanzibar, who have been, I see my buddy here, who have really been doing this hand in hand. At MCGL does not implement, we support the governments to implement their priorities, and so we do everything hand in hand. We co-design, we co-plan, and we co-implement with our governments, particularly with the IVD units. So I would like to really thank the IVD units and both governments for really, they have a lot of partners coming to them, and they've really prioritized this because they've understood the great need. I would also like to thank our donor, USAID, who has really been amazing and also very adaptable, which sometimes we don't see with donors, but Freddie, if he's here, and USAID has really understood what the needs are, and they have also prioritized making sure government priorities are first and have been a great advocacy for this funding. And then finally, for the other stakeholders, our co-implementing partners, we've tried to do everything in collaboration and avoid duplication. But last but not least, I would like to thank Dr. Mary Rose Giatis. This woman never sleeps, and she has really been a visionary and has really pushed this program, and I think all of the panelists would agree. She is working hand in hand to really address the needs of Tanzanians, the individuals down at the ground level, working with the nurses, the doctors, the medical officers in charge, going out, doing house to house, and all of these amazing things, and then seeing what is needed, such as we were seeing measles outbreaks and seeing routine immunization was dipping down, and then advocating with USAID, look, this is what we need to do next. So Mary Rose, congratulations. I'm really excited to hear this panel, and to the whole MCGL and JHPEIGO team for supporting Mary Rose and the governments to get where we are. I'm really excited about the session. It's very near and dear to my heart. I was just in Zanzibar last week looking at some of the outreaches and seeing the impact of the great work that we're doing and being able to use some of the COVID-19 funds to address zero-dose children, to address some latecomers with COVID-19, and really seeing the impact of that, including addressing HPV and some underdosed adolescent girls. So thank you so much. I hope you enjoy the session. I know I will. Thank you, Mary Rose.
Thank you. Thank you very much, Alice, for your very, I could say, inspiring welcoming note. So our next expert in immunization, at the same time, he's our donor. He's young but very dynamic upstairs, and he runs with the speed of 10G. And he's the one actually an activity manager for our program, which is named Momentum Country Global Leadership. And he has been very, very supportive throughout, from the beginning to where we are now. And I really like Dr. Freddie to come forward and give us a few remarks. Karibu, Doctor. Pigeni makofi basi, anatulipa mshahara.
Habarini za mchana. So itakuwa ni vizuri nikiaddress Kiswahili. Yeah, okay. Thank you so much. First and foremost, I'd like to take this opportunity to thank the Almighty God who has given us the privilege of life and health. We are here gathering to reflect what we do in terms of what we support in the health, but at times we forget that that privilege has been availed to us as a privilege, not a right. So truly I'm humbled to stand before you and to see one of my chief there, Daktari Maboko. Mungu akubariki sana. And I'd like to thank my colleagues from USAID who have accompanied me here. I know it's not easy, and now I've realized how the journey of politics starts. I've never stood in this podium such as this, but I'll try my best. So I'd like to acknowledge the presence of the government of Tanzania, both mainland and Zanzibar, the directors and heads of unit, the RMOs, protocol observed, mabibi na mabwana. So allow me first to thank you on behalf of US government and USAID Mission Tanzania for making us part of this important summit. It truly marks an important step forward in our joint reflection on lesson learned for pandemic preparedness and response. We know all the pandemic has left behind a resilient infrastructure, including testing, center supply chain, trained healthcare personnel, which can now be strategically leveraged to bolster and support primary care health services. So in these unprecedented times, our ability to adapt and innovative within our healthcare system is paramount. So leveraging PHC for this purpose hold immense potential. The integration of these vital health services is not only timely, but also imperative in our ongoing battle against infectious disease. So we know today we gather to explore innovative approaches, share insights, and chart a path forward towards more effective and comprehensive healthcare delivery. So your presence here signifies your commitment first, and to improve public health, and together we can make significant stride in this critical endeavor. So allow me to be brief. In conclusion, I would like to extend my thanks to the organizer, the government of Tanzania. Partnership, I know a lot have been said from Alice. I remember when we started to plan, it was a very intense exercise, but we made it, and here we are. So I'd like to charge us really to be resilient, to ensure that the platform that has been built by the COVID-19 preparedness and response is well leveraged to the primary health care to ensure that we have improved coverage, both under 5 and other antigen that are beyond under 5. Asanteni sana kwa kunisikiliza.
Thank you very much, Freddie, and thank you very much for your support. USAID team, asanteni sana for joining our session. So our third speaker will be now the government, Shikamoo Serikali. And we have our one and only Assistant Director of Health and Social Welfare and Nutrition from the President Office, Regional Authority and Local Government. They've just finished another session on HPV vaccination. Dr. Paul Chaote, karibu sana for whatever you prepared for us. And I just like to remind our opening session that we are taking only 3 minutes. Karibu, Paul.
Habari za jioni. Mkurugenzi wa tiba kutoka Wizara ya Afya Zanzibar, mkurugenzi kutoka JHPEIGO, Chief of Part JHPEIGO, mwona pale Dr. Melilozi, ndugu zangu panelist na ndugu washiriki kwa pamoja. First and foremost, I would like to take this opportunity to thank all our donors and the partners whom we are collaborating in support of immunization services in our country. We acknowledge and we do believe that continuous partnership and collaboration is the only way to succeed to immunization services in our country. As we understand, the government on its own cannot provide for all the needs that are required to be delivered to our citizens. As a government, we have been striving for quite a long time to make sure that we have a sustainable immunization program, but also intervention at the level, from the level of the community to the level of the facilities. With all the success that we know, Tanzania have been among the stable countries that have sustained good performance in immunization services. However, the past 3 years have been a bit turbulent, as we know, due to the COVID pandemic. But yet we are able to revitalize the services, as now we are seeing a modest increase of the coverage in general in different vaccines. And this is not only due to the government effort, but also our partners whom we are collaborating. We do acknowledge the support from Gavi, USAID, and the other implementing partners, JHPEIGO, through MCGL, CHAI, but also Afya Yangu, not only MCGL, Path and Girl Effect, among other partners whom they have been supporting our programs in Tanzania. As a PLH, we do pledge our continuous support for all partners, and we are ready anytime to make sure that we perform better. At this moment, my team is almost here, except for Abdul from Zanzibar. The rest are the PLH family. So I will not speak much. They will be the one whom they will be speaking, because they are the one who actually doing the job. Thank you very much.
Thank you very much, Dr. Paul Chaote. So our next speaker will be our one and only Director of Preventive Services from Zanzibar. And I really wanted to also acknowledge the presence of the Deputy Director of Preventive Service in Zanzibar, Dr. Fatuma. Can you stand up? And they've balanced gender in Zanzibar, yeah? So Dr. Slim has also been one of our main partner in implementation of MCGL program in Zanzibar. So karibu Daktari for your remarks.
Thank you, Dada Mary, for giving me this opportunity. They are my colleague directors from the government and the partners. Good afternoon.
Good afternoon.
Protocol observed. Honestly, it's a pleasure to be here in one of the most important innovation in human history. We all know that to eradicate infectious disease from the face of the earth, we require vaccine. So with this context alone, it simplifies that we are actually at least assuring people that they will be okay. Zanzibar, in my own context, we observe a serious change in paradigm shift when COVID hit. Our island is a tourism island, and people have other activity, but when COVID came, it actually affected everyone work in terms of life and in their livelihood. But try to pick up, we observe that the parameter of all those vaccines that are more important were also dropping, endangering more people for other infectious disease, which are definitely, majority of us are around us just because of our topographical nature. So having MCGL, JHPEIGO, Gavi, and USAID, who has been a supporting mum through this, we have managed to sit together and plan country-specific innovation. And today we sit here, we have seen a reversible situation in making sure every little girl or boy in Zanzibar who is eligible for vaccination is being inoculated, and only then we can safeguard them for their future, and they are the future investment for our country. So we really don't have much, but I do appreciate how we have been working together to ensure that we go out of our way to make sure those 0 doses and those 100 doses are also covered. Before intervention of MCGL, Zanzibar has only 14% of girls who are prevented for HPV, which means 86% of those girls were at high risk of being infected by human papillomavirus, which causes cervical cancer. After the innovation, we are now at 95% coverage. That translates the change in paradigm in how we see things in relation to how these girls are now safeguarded. This is just part of the contents. And if we continue to do it that way across Zanzibar, I believe we will have a very future-proof nation in relation to infectious disease. So I'll take this opportunity once again to thank you personally, Dada Mary. This lady doesn't sleep. Yeah, she's there and she's everywhere, in Zanzibar and in every region of Tanzania. And God will bless you, and will bless you all. Thank you very much.
Thank you very much, Daktari. We know that you have lived in UK, and we can hear your accent. So with that note, we thought as a team, it's going to be very important for you to learn a little bit about immunization vaccine development program in Tanzania, and just a high-level overview, and also where we are with the journey of integration. We are all aware of the fact that when COVID-19 heated up, we all concentrated on COVID-19, and then it contributed to decline routine immunization services. So our babies under 5 were not vaccinated last year. Our girls were not vaccinated last year with HPV. So the coverage of under 5 vaccination and HPV really went down, both in mainland and Zanzibar. So we have in front of us the program manager for mainland. Is called Dr. Florian Tinuga, and I normally tease him by calling him Tinu Boy. And he's a very strong leader, and he has been very vibrant for the past 2 years, supporting us all 26 regions, making sure we align with the government priorities and guidelines. So karibu Daktari for what you have prepared for us. So you can all look at on your right side. There's a small screen. Karibu Daktari.
Asante, thank you, Dr. Mary Rose. I'm Dr. Florian Tinuga. I'm the program manager for immunization, Tanzania mainland, the department which is in the Ministry of Health under the Directorate of Preventive Health. So I'm going to speak in a nutshell how the COVID disrupted the routine immunization and what we did, where are we, and where we want to go. As an overview, immunization program in Tanzania, it had been so good before the pandemic, except for the 2 antigens, which is measles, rubella, the second dose, but also the HPV. The rest of the antigens we are managing, 14 antigens, they were all okay. They were above 90%. And then we started seeing the decline of all the antigens in 2019. And during the pandemic, the situation went worse because the pandemic, we believe it compounded the challenges. And we remember at that time, every resources, every coordination perspectives, every systems was directed to response towards the pandemic. So this is how each antigen was affected in a summary. So to say, not antigen did save from the pandemic. And observing this slide, we had accumulated a number of 0 dose, the director has said, 0 dose, and the majority of the 0 dose was found into pentavalent, penta-1, but also MR vaccine, and in particular MR2. In the science of vaccination, if all antigens are affected equal, the first one to show the effect is measles vaccine. So this is what happened. We started seeing the outbreaks of measles rubella from the late 2022, but maximum we had numbers in January, February, as you see. So all over the country, we had a lot of outbreaks of measles rubella, and due to the efforts I'm going to mention next, the cases have been declining from January to September, as we are seeing on the graphs. So these are the efforts we put in place. We had to develop a strategy, and that strategy for revitalization had 3 components. One was to catch up, meaning we had to find out those who missed the vaccines, in simple. Recover, we had to vaccinate them, and we are continuing vaccinating them. And then the second component is to sustain. Sustaining meaning returning on the normal road towards 2030 strategy of vaccinating everyone. So this is the strategy. Now, how did we implement this strategy? We did implement through 2 approaches. One, it was to find out the cases and set down the activities, but 2, to do integrations. So the integrations Dr. Mary and others have been mentioning, this is what we have been doing. And now, currently here, this is where we are. At the beginning, in January, as I said, we started by having 1.4 cases, children who missed the vaccines. And due to our revitalization strategies, now we have vaccinated almost more than 50%. But again, in HPV, you remember when we started, we had 69%, but now we have gone around 86%. This is to show the strength of integration, the strength of catch-up, the strength of recovery, and the strength of sustainability. So what have we learned from all these lessons learned from COVID-19 and integration? We came to realize the big mistake we did during the response. We took COVID as alone. This is what happened. We left the other immunization services alone. So the lesson, integrating the COVID-19 and routine immunization, we came to realize it later. And from that then, we learned the following. One, strong coordination, partners alignment, and resource mobilization was key to the integration. But then, integrating is cutting across, integrating for the partners, integrating the vaccines distribution, integrating the storage, integrating the data management, but also, above all, community engagement is above all. This is why today you have a community person from Arusha, where integration, I guess they are going to speak, but I think Kilimanjaro, Arusha, Dodoma, Singida, Morogoro, and others, they will speak about what are the strengths and achievements for the integration. Thank you so much.
Wow. Thank you very much, Tinu Boy. So Tinu Boy, when he started 3 years ago, hakuwa na mvi jamani. Tumempa mvi na makazi yetu mengi. Pole sana, Doctor, and thank you very much for the last message of integration. You said integration everywhere, so we should also go back and integrate with our families and our partners, husbands and wives at home. And with that note, we are moving to our second phase of the panel, whereby the speakers in front will share with us experience on what they've done to contribute to improve coverage of the 3 main elements. 1, COVID-19, 2, under 5 vaccination for children, and 3, HPV vaccination. So our first panelist will be Dr. Victorina. We are doing it for a purpose in order to promote women empowerment, yeah? So Dr. Victorina is coming from Singida. She's the regional medical officer, very strong and vibrant, and she has been implementing this program for the past approximately 2 years. And we really wanted to learn from her as a regional medical officer, what are her roles? What is she doing to make sure that the Council Health Management team implement integrated service? What have they done and what is the success story? And what are some of the key challenges she has experienced? Karibu Daktari. 5 minutes, please. I know you want to talk more.
Asante sana Dr. Mary Rose, Honorable Permanent Secretary from Ministry of Health, Zanzibar, Director of Preventive Services from Zanzibar, Assistant Director from PRALJ, Program Manager, Country Director from JHPEIGO and USAID, my fellow panelists, and dear participants, protocol observed. Good afternoon.
Good afternoon.
Is it afternoon or evening? Okay, thank you. My name, as I have been introduced, is Dr. Victorina Ludovic. I'm the Regional Medical Officer for Singida Region and also an Assistant Administrative Secretary in Singida. Probably I should start with RMO's supervisory role and the contribution during planning and implementation of COVID-19 and routine immunization integration services in Singida region. My priority and my overall supervisory role is to make sure that I supervise all the health services in the region, including curative, preventive, promotive, and we also have a lot of infrastructure, including construction and all that, but also to link the RHMT vertically to the RAS and Ministry of Health, as well as the PRALJ, and also to supervise the CHMT and the health management teams in order to make sure that they provide quality health services in the region. And in this particular event, especially in the immunization, my role is to make sure that immunization services and coverage are improved in the region. This starts from the ordering of the vaccinations from MSD, receiving them and maintaining all the cold chain management, and also distributing them to the district councils, but as well to supervise during the provision of services. As we all are aware, and as our program manager has mentioned, that during COVID-19 pandemic, immunization rates were substantially affected in almost every region, and Singida being one of them. And when we introduced the COVID-19 vaccine, Singida was among the lower performing region. We almost had only 9% and below. So the reasons why we were performing very low is because this also was a new vaccine, so the awareness was also very low among our people, but also there was some myth and other issues that were going around which attributed to the negative attitude toward the vaccine. But also we had limited resources to facilitate and to reach the targeted population in the region. We really thank the Ministry of Health and PRALJ for providing us the partners, MCGL being among the major partners in Singida. And also we had EGPAF, JSI, and CHAI who came to join the effort in Singida and improved the services. So what our partners did, and especially MCGL, we sat together and planned together to identify the gaps that we had, including creating awareness. And also we managed to build capacity to our healthcare workers, including RHMT and CHMTs, and the community health workers who were very supportive initially to find out where were these children and other missing targeted population. So we had like a refresher training to all the healthcare workers to make sure that they provide the targeted and the quality immunization services. After the joint planning, we planned also for outreach services, which we also conducted it jointly to the lower performing health facilities, and this involved community health workers as well. But also we have integration of COVID-19 vaccination and routine immunization of all the vaccine, including HPV. The community health workers, when they move to conduct these outreaches, they carry all the vaccinations and provide them to the targeted population.
Doctor, 1 minute left.
The models that we use was house to house, especially when we had epidemics, but also we used our health facilities and community events that were around. And school programs was also conducted, especially for HPV and to other issues. There were joint vaccine distribution and also joint supportive supervision. After doing all this effort and integration, there was a very big change that for routine immunization, before the support from our partners, we were at 89%, and therefore we improved to 114% by December 2022. And for COVID-19, as I've said, we were at 9%, and therefore we improved to 98%. And for HPV, it was 55 when we started integration at World Vaccination Week, so we moved to 98%. So these were the achievements that we got from the integration of services. To conclude my presentation, I should also acknowledge the Minister of Health, IVD team, Dr. Tinuga, who came also to join the effort in Singida, together with Pure Raj, Josephine, she's not around, but she came and tried to solve our challenges that were existed. But above all, MCGL, please thank you so much for coming to Singida and join the effort and improve the services. I think I should end there. I have a lot to say. Thank you so much.
Big round of applause for Daktari. Asante sana Daktari. So our next panelist is one of our very strong regional medical officers in Tanzania. So for Dr. Kanga, all his indicators are in green. I don't know how he operates. So today he's going to give us the secrets of leadership, management, and sustainability. That's why he's here. So Dr. Kanga, with your experience in routine immunization, COVID-19, tell us how are you managing your team to make sure that you get sustainable results, even without funding? It's the only region when we implement and we don't provide financial support at a certain period of time, the indicators remain green. Karibu Daktari.
Yeah, thank you very much. Good evening, ladies and gentlemen.
Good evening.
As I've been introduced, my name is Dr. Jerry Kanga. I'm the Regional Medical Officer for Kilimanjaro region. I've been given an opportunity to talk on how the leadership and good governance can influence the effective implementation of the NA program. So we've cited Kilimanjaro as an pilot. He mentioned that I'm a strongest leader, but for sure, I'm trying to be a strongest leader. Leader, I'm not a leader, but I'm trying to do it. So, all the protocol has been observed. So to start with, it has been written clearly by the WHO that leadership and good governance is one of the key blocks in influencing the health delivery system wherever in Tanzania or anywhere. And it is being stipulated due to the following reason. As you know that leadership and good governance, it promotes or increases an accountability in a working station. Also, leadership and governance, it provides a transparency. And once you have a transparency, it means you promote a good management of the resources, especially finance, and you provide a confidence to those whom you are working with them so that there is trust on you as your leader. Another thing, good governance, it provides a vision and objective of the institution or of any kind of the intervention you are providing to that specific area. Again, leadership and good governance provide a guidance and interpret the durations and the speed of the intervention you are implementing in a certain institution. So all these are the advantage of having the leadership and good advantage. So after having this, we did what in Kilimanjaro. I remember my career, I started as a regional medical officer. I started in Ruvuma. So I joined Kilimanjaro last year, June. So after I reached the Kilimanjaro region, I find the region was among the 3 least performing regions in Tanzania, especially in the area of COVID indicators, and generally the all indicators, even the routine immunization. So one of the most things which we did in collaboration with the RHMT and in collaboration with the CHMT all over the region. So the first thing which we did, we conducted a baseline survey. We conducted a baseline survey just for a sake to come up with the implementation status, with the performance status of the all indicators in the health perspective. So what we find, majority of the health indicators were poorly performed. And most of the indicators, the status of which of the performance was even 50% of the nation target. So after knowing the situation now of the performance indicator, then we come up into a certain step, a second step. We come up with a priority areas. And our priority area was based to the least performing indicators, which we observed during the baseline survey. So we come up with 13 priority areas. And immunization, routine immunization and COVID was our second priority areas. So having this priority area, it enforced us to put our little resource we have, to put the strategy in making sure that we increase the level of the performance from being least to the higher performance. The third thing we did, after we set the priority area, again also we set the local target. As we know, we have the national target, and for Kilimanjaro, what we decided, based on the baseline, the result of the baseline, we set a local target. And in the local target we set, the performance, we set a target of which was higher than the national target. That one, it helps the service provider, it helps the HMT to have an energy enough in making sure that they achieve to what we planned to reach the local target. The other thing, after we set the local target, we come up with an implementing strategy. And the majority of the implementing strategy we used. First, we involved the community leaders from the higher level to the down level. So we mostly involved the regional commissioner, we involved the regional administrative secretary, we involved to the lower level, we involved the executive officers, we involved the village chairperson, we involved all the community representatives within the community level. The other thing which we did, we conducted what we call, we come up with a stratum training. So we specify the specific coordinators which are working within the RHMT and CHMT. So we take the all DVOs and the DRS core, we give them training. We mentor them on how to have, we give them the knowledge on how to give the leadership skill. Again,
Doctor, you have 1.5 minutes left.
So we provided the capacity building to CHMT and RHMT. We are aiming just to provide some leadership skill as well as some supervision skill. Again, what we did, the local target which we formulated during the baseline survey, we shared all these local targets to down there, to the lower level, which is the CHMT, and to the health facilities. What we have seen that this target, it is known in the higher level, of which it is RHMT and CHMT. But the target, it is not known to the lower level. So what it happens now, you might be having a certain dream of reaching to a certain higher level, but the service provider doesn't know. They are lacking to know the decision point. So what we did, we shared all this local target from the higher level, which is the regional level, up to the health facility level. So doing this, for sure, it helps us to increase the coverage of the most of the health indicators. So maybe to finish up, what we are planning now to have a sustainable performance, or to have a sustainable to what we have gained from this performance. We are proposing, based on the experience we get, we are proposing that it is better now, the intervention we have, we must now include to our RHMT plan as well as to the CHMT plan. So that one, it will be a sustainable means of sustaining this performance. Second, means of sustainability, it is to involve this community leader representative. Once we involve the community leader representative, it means the leaders will be owning this program, will be owning this intervention. In doing so, they won't agree at a time to leave this a good performance to just left ahead. The other thing, it is to use the existing integration approach which you are now using. I think when you integrate COVID intervention as well as a routine vaccination, automatically using this little resource, you'll be together implementing both COVID and the routine vaccination.
Thank you, Doctor.
And maybe the other thing, it is maybe to train the RHMT and the SHMT on the issues of leadership skill. Once you train, because majority of the CHMT and the RHMT, they are just coming from schools, and they have been given a big post as the maybe DMOs, as the DRS co. So we're thinking that it is better now to train them in the area of leadership skill. Thank you very much.
Thank you very much, Doctor. That was really very, very insightful. We have learned how you managed to improve coverage in Kilimanjaro, looking at 6 main components I've summarized: assessment, prioritization, setting the targets, and sharing at the lower level, and engagement of the community leaders. So those are the key take-home message for us all. So let's move to Zanzibar. Zanzibar, oye. So, was Zanzibar impo? Okay, so now we are moving to Zanzibar, and we have our program manager from Immunization and Vaccine Development Department, and MCGL has supported some intervention in Zanzibar, and we really wanted to learn from Abdul how they've been able to implement COVID-19 and routine immunization integrated services, looking at the primary healthcare model. And in addition to that, Zanzibar also, that have been able to implement the so-called HPV+. Karibu, Abdul. Tell us your experience and lessons and the key challenges as well. Karibu.
Thank you. Thank you very much.
5 minutes, please.
Thank you very much, Dr. Mary Rose. And thank you, my friend, Dr. Fred, my boss, Dr. Slim, and Dr. Fatma, Dr. Chawote, and my twin, Dr. Tinuga, protocol observed. First of all, I would like also to thank MCGL for supporting immunization services in Zanzibar. Zanzibar, as other many countries in the world, has been also affected by the COVID pandemic. And before 2019, Zanzibar had a immunization coverage of over 95% for all antigens. But since 2020, 2021, and 2022, the immunization coverage affected and went down up to around 80%. This coverage of 80% we have never been experienced for the last 15 years, except for the past 3 years post COVID-19 pandemic. So what we did in 2022 is to change the approach of having that, to make sure that we are recovering the immunization coverage and be back to the target which the government has been set at, which is over 95%. So the approach we used is to make sure that we are integrating the services, because the first approach was to deliver these services separately. If you go to the community, you deliver the COVID-19, then the other day you go and deliver the routine immunization to the children, but we said no, we can't move like this. So we decided, in collaboration with partners, especially MCGL, to make sure that we are going to deliver the integrated services. And in these integrated services, what we do is to make sure that we are delivering all packages at a household level during the outreach, and also at the health facility level as one package. So all organized outreach services now in Zanzibar, when we go to the community, we make sure that we vaccinate COVID-19, we vaccinate HPV to the adolescent girls, but also we vaccinate the children who are eligible for childhood immunization. And in this approach, because the concept of integration is not new in Zanzibar, but the approach we are using now is completely different in terms of eligible target population, but because now we are targeting adults, adolescents, and children, while previously it was only integrated and targeted the childhood immunization. That's the difference. But the second one is the concept of the methodology of delivering the services. In previous concept that the integration services was delivered at a static services. You go to the community or at the health facility, whereby you only deliver services at a static point. But now we change the approach to house-to-house approach. And this is a new approach which we adopted from the last campaign, 2019 campaign, where we did MR, polio, and vitamin A house-to-house approach. It was a new concept because previously it was a static campaign. But since last year, when we had an outbreak of measles, we decided to start delivering the service by house-to-house. So from 2022, up to now, we are delivering the services by doing house-to-house when we go in outreach services. So this approach has improved our immunization coverage from from below 80%, which was in May this year, up to over 95% by September this year. So by delivering house-to-house approach, we are make sure that we don't left any child behind, because we are at the household level, whereby we approach the household family members and make sure that all unvaccinated children and zero-dose children have been identified and vaccinated. But also, the moderator also mentioned about the HPV plus. In Zanzibar, we adopted the concept of delivering the HPV plus. And HPV plus is not a new concept. It's just an idea that we are delivering HPV vaccination, but with other health intervention. And in this package, we are delivering HPV vaccine. We are doing also a vision screening to the 9 years to 14 years adolescent at school. But also we are giving them a reproductive health education and nutritional status. So these 4 packages at a time, we call it a as known as a HPV plus. And this concept helped us a lot in Zanzibar because before 2023, I think most of you know that the HPV vaccine in Tanzania has been introduced in 2018. It's about 5 years ago. And since 2018, we have never reached 70% coverage in Zanzibar. But after introducing this concept of doing HPV plus, whereby we are delivering 4 interventions at a time in school, but also in collaboration with Ministry of Education and school committees, together with involvement of private sectors, the coverage of HPV in Zanzibar now is over 95%. Because of the time, let me end up here. Thank you very much.
Thank you so much, Abdul, for keeping the time and giving us lessons from Zanzibar. So HPV plus, more than just vaccine, but that's how we have been trying to integrate and make sure that we implement primary healthcare model. Now we are moving to the last panelist. Now we are changing from English to Kiswahili so that we can be able to learn more from the implementers. So tunahamia Morogoro mji, kasoro bahari, na tuna expert wetu wa chanjo ambaye anasimamia masuala ya chanjo katika ngazi ya mkoa, ambao wanaitwa Regional Immunization Vaccine Officer Masumbuko, ambaye ana experience ya muda mrefu sana kwenye masuala ya chanjo. Kwa hiyo tungeomba Masumbuko utuambie sasa focus kwenye technical component kama mratibu wa chanjo, kwenye context ya integration. Wewe kama wewe, wajibu wako ni nini? Na katika wajibu wako huo kama mratibu wa chanjo, tuambie mambo kidogo kuhusu planning, tuambie mambo kidogo kuhusu coordination, tuambie mambo kidogo kuhusu cold chain management. Sawa? Karibu. Karibu bingwa, karibu.
Asante sana. Kwanza nitoe shukrani za kipekee kwa kutambua uwepo wa MCGL project katika mkoa wetu wa Morogoro, lakini pia ni shukuru wadau kwa kuendelea kutusapoti kuwezesha kufanikisha utoaji wa huduma za chanjo. Moja majukumu makubwa kama usimamizi wa huduma za chanjo ngazi ya mkoa ni pamoja na kufanya planning ya any activities ambazo tunategemea kuimplement. Na on planning, we are always planning together with MCGL staff at Morogoro, where we discuss the scope of the work, we set the targets, and also we discussed about the participant of the exercise, and also how can we monitor the outreach itself. And also tukifanya planning session pamoja na MCGL staff, what we did to make sure that we have all the items required kwa ajili ya kuimplement outreach services. So tunakuwa na uhakika kwamba tutafanya distribution ya chanjo and the other supplies from the regional level, district up to the facility level, and all of this tunashukuru we have been financed with a MCGL project. So MCGL anatusaidia sana kusafirisha chanjo kutoka ngazi ya mkoa, wilaya hadi ngazi ya kituo. Lakini pia kabla ya ku-implement any activity, we have the pre-planning meeting with all of the implementers. Kutoka kwa MCGL staff, RHMT, CHMT. We discuss together all the target ambayo tumeziset, lakini pia we ask if we have any, kama tutakumbana na tatizo lolote wakati wa kuimplement zoezi, na kama kuna shortage ya kitu chochote ikiwemo chanjo ama tools zozote ambazo tutazitumia wakati wa zoezi. Na during coordination, we will make sure that every members ambaye atakuwa included kwenye outreach campaign anakuwa na TOR zake ili aweze kusimamia vizuri kampeni ambayo inakwenda kutekelezeka. And through that, during implementation, RCHMT tunafanya supervision wakati wa utekelezaji wa zoezi, ambapo we are looking for the quality of the service provided there from the healthcare workers and also the vaccine itself. Chanjo zinazotolewa zina quality ama ubora unaotakiwa. And also we are looking for the tools used, kwa sababu we have some tools ambazo tunatumia collect information data. Je, hizo tools, are they used well? Are they documented well? And also wakati wa zoezi, we know we have captured some of the data. So we have our systems which ambayo ina capture na information zote ambazo tunazipata wakati wa zoezi, kama VIMS kwa maana Vaccine Information Management System, and also have Chanjo COVID system. So during the implementation exercise, we always tunafuatilia kama taarifa zote ambazo zinakuwa captured wakati wa zoezi zinaingia kwenye mfumo na tunaweza kuziona kila siku. So we have daily calling data every day wakati wa zoezi. And sometimes we use Google Sheet kama tunaona mfumo wetu hauko stable sana, we have the alternative way by using Google Sheets. Lakini pia I've observed some of the benefit of integration exercise in Morogoro, and one of them niseme tu kweli kwamba before MCGL came to Morogoro, the highest HPV coverage reached was 67 since we've been started to have HPV vaccination in Morogoro. But now we are speaking about 100 and above HPV coverage. And all of this is due to MCGL support. And also, kwenye issue ya vaccine management, kama wasimamizi wa chanjo ngazi ya mkoa na halmashauri, tunahakikisha kwamba ubora ama ule mnyororo wa baridi unazingatiwa kwa kuhakikisha RTM, maana remote temperature monitoring devices zote zinakuwa zina kifurushi cha kutosha, na all of them lazima tuhakikishe zina transmit data kwenye server ili tuweze kuona the current temperature ya jokofu husika kwenye certain facility na kufanya maamuzi kama tutaona kuna any abnormal temperatures. From there, niseme MCGL has made changes to Morogoro. We are now at Morogoro looking on data quality, not coverage again. We have made the coverage more than 100%, but now we are looking for the quality of the data. And also we are thinking about sustainability. If MCGL gone, kama ataondoka Morogoro, tutakuwa na hali gani? Kwa sababu we have seen some changes, big changes at Morogoro kwenye eneo la chanjo. So we are thinking about sustainability. And also, as we know, Morogoro ni mkoa mkubwa sana. We are speaking about mkoa Morogoro una jumla vituo vya huduma 598 na vinavyotoa huduma za chanjo ni 382. So na vingine viko more than 600 kilometers from the regional level. So ni mkubwa sana, and you know always resources ni ndogo, but we are trying to make sure that resources ambazo tunazipata kutoka kwa MCGL tunaweza kufikia hata vile vituo ambavyo ni vya mbali sana. 1 minute left. Asante. So ninachoweza kusema for MCGL, they have been changed the Morogoro kutoka kwenye mikoa ambayo ilikuwa inasemwa vibaya kwenye eneo la chanjo, and recently tunasemwa vizuri kwenye eneo la chanjo. So the issue we want to maintain the status recently kwamba tufike ambako tunataka kufika. Asante daktari.
Thank you very much Masumbuko. Makofi mbona kama yatosha. Thank you so much for sharing experience ya Morogoro. Tunashukuru sana, na key message kwenye experience sharing yake kwamba sustainability is key. Kwa hiyo to align na presentation ya Dr. Tinuga, catch up, recover and sustain. So tunahamia Kagera. Pasha kwa mabag. Haya, sasa Kagera tuna mtoa huduma wa afya ambaye vile vile ni RCH in charge. Ana experience kubwa sana ya kutoa huduma za mkoba na huduma mbalimbali za afya pamoja na huduma za chanjo. Kwa hiyo leo atatuambia yeye kama mtoa huduma wa afya, sio kama in charge, kama mtoa huduma wa afya. Hivi mnaendaje huko kwenye community? Mnaanzaje kubeba hizo chanjo zenu kwenda kuchanja hizi huduma ambazo tunataka ziwe jumuishi. Sio kuangalia chanjo moja, lakini kuangalia chanjo kwenye makundi yote. Tupe experience yako pamoja na changamoto unazozipata. Karibu Adela.
Asante daktari. Kwa majina naitwa Adela Francis, nimetokea Kagera, Bukoba Manispaa, kituo cha afya Rwamishenye. Niko hapa kushare experience nilionayo kwenye chanjo ambazo ni under 5, HPV vaccine pamoja na COVID-19. Mimi kwa uzoefu au kwa kupenda kushare na nyie nilitumia tu njia nyepesi ambayo kwa walimu wanapenda kusema kufaragua. Nilichukua vial 3 za PCV vial, Penta vial na JJ vial. Tunazifahamu nikaziweka kwenye Ziploc zile zilizotumika kusudi nitolee elimu ya afya. Nisitumie nguvu sana kwa sababu watu walikuwa kwa kweli hawarespondi kwenye chanjo za COVID. Basi nikawaambia, sasa mnaonaje? Watoto wetu tunawachanja mwezi 1.5, 2.5 na 3.5. Si mnawaleta? Ndio. Chanjo mnazifahamu? Hapana. Nikaziunganisha. Unaweza ukanichagulia chanjo labda ambayo imechanjwa na mtoto wako? Akasema hapana, na zile virus yani almost zinafanana. Basi nikasema huyu aliyekutengenezea ya mtoto wako wa mwezi 1.5, 2.5, 3.5 na wa miezi mwaka 1.5, si ndio? Ndo huyo aliyekutengenezea chanjo ya JJ. Kwa hiyo watu wakashangilia, wala sikutumia nguvu sana. Kwa hiyo pale kituoni ukija unakuta watu wa huduma wanatoa lugha nzuri kwanza, alafu elimu ya afya kabla hajampa huduma, alafu kwenye kuleta mtoto wake yule wa kuchanjwa ndo hapo yeye anapatia chanjo ya COVID-19. Lakini tukaona hapana, huyu ana uwezo wa kuja kituoni kwetu na kupata huduma. Je, tunawezaje sasa kuwafikia wale ambao wako mbali kuwafikia? Basi tukawa na huduma tembezi. Huduma tembezi tunabeba chanjo zote, HPV, JJ, Sinopharm, P5, zote tunabeba, tunaweka kwenye vaccine carrier yetu. Tunakuwa na huduma ya mkoba, nyumba kwa nyumba, ambaye labda mle tunaweza tukakuta watoto, kuna watoto ambao wameasi chanjo, tutampa chanjo anayohitaji. Lakini mle tuna house girl, wadada wanaotusaidia kazi, wengine hawakubahatika kwenda shuleni, tutampa chanjo ya HPV. Lakini mle tuna mabibi ambao hawawezi kumove from one place to another kuja kupata huduma, basi anapata chanjo yake ya COVID. Kwa hiyo tumefanikiwa kwa kutumia njia simple ambayo imetuwezesha kwa kweli kuvuka lile lengo. Nadhani hata mkiangalia kwenye DHS2 Rwamishenye inafanya vizuri. Lakini pamoja na hapo wamechukua hiyo experience, kwa sababu ukimwambia mtu chanjo ya COVID hujamuelezea nini maana ya chanjo, umuhimu wake ni nini, anakipata akichanja hiyo chanjo, hawezi kukubali kiurahisi. Lakini ukileta chanjo, kwa mfano tulivyokuwa na chanjo hizi za watoto kampeni, wamama wengi wanaleta watoto wao kwenye chanjo. Lakini ukimwelezea kwamba jamani, huyu aliyekupa hiki ndo huyo aliyekupa hiki, huyo aliyekutengeneza ukawa wewe ndo huyo anayetaka kukumodify wewe uendelee kuwepo. Kwa hiyo hatutumii nguvu nyingi kwenye kituo changu cha afya na manispaa nzima. Lakini pamoja na hapo tukasema hapana, twende sasa wale ambao DMOs wanatusupport, MCGL wanatusupport, tunawapataje? Tunawakusanya kwenye sehemu za tunaita ofisi za kata au vituo vya kutolea huduma, si ndio? Wanakuwepo. Tunaendelea tena kutoa elimu ya afya ile ambayo tunakuwa na vivaio vyetu na ni empty vial, tunakuwa na chanjo zetu. Kwa mfano ile tunakuta sasa mtu anakuja kupata huduma moja, labda alikuwa amekuja kwa ajili ya uzazi wa mpango, lakini kwa kumshawishi hivyo tunakuta ameshapata huduma zaidi ya moja. Atapata uzazi wa mpango, atachanja yeye mwenyewe chanjo ya COVID, hapa anaweza akaskrini cervical cancer, alafu akaskrini cervical breast cancer. Kwa hiyo tunatoa hizo ambazo ni integrated services kwenye kituo chetu. Asante.
Asante sana Adela kwa kushare experience kama mtoa huduma afya. Mwaka kesho tutakualika, utakuja kutoa experience kama in charge. Sawa eh? Thank you so much. That was fascinating. Kwa hiyo tuhamie sasa kwenye community. Community oye. Haya, tunahamia kwa mtoa huduma yetu wa afya, mtanashati, kapiga shati lake la kitenge, David Liza, ambaye anafanya kazi nzuri sana. Eneo linaitwa Oldonyosambo, Arusha huko. Kwa hiyo David, wewe tunajua ni mzoefu wa muda mrefu kama mtoa huduma afya ya msingi kwenye jamii. Na tangu tunaanza COVID tulikuwa wote, mpaka tuna integrate tuko wote. Hebu tuambie basi, tupe ubuyu kidogo, unafanyaje kazi zako kuhakikisha kwamba makundi yote matatu yanachanja, afya wa Masai. Maana wewe ni Masai tunajua, na unako kuhudumia ni wa Masai, na tunajua wa Masai hawaishi kwenye nyumba, wanaishi kwenye boma. Karibu David.
Asante, habari za jioni. Kama daktari alivyonitambulisha, naitwa Swingi David Liza, ni Masai, natokea Arusha DC, mkoa wa Arusha. Kwanza nishukuru sana MCGL inayotekelezwa na JHPEIGO chini ya ufadhili wa USAID kwanza kwa kunipa fursa ya kuja katika kongamano kubwa hivi. Vinginevyo mimi Masai sijui ningeweza kwa jinsi gani kukaa na watu wakubwa. Kwa hivyo nashukuru sana kwa hilo. Sasa nijikite katika swali ambalo nimeulizwa na daktari. Historia fupi wa Masai, nadhani mnajua kwamba Masai sisi huwa tunaishi kwenye boma, na Masai sisi miji imekuwa kama adui kwetu. Kila mji unaposogea inabidi si tuende mbali zaidi kwa sababu ya malisho. Kwa hivyo imepelekea kwamba Wamasai tunakuwa mbali na maeneo ya kutolea huduma. Mimi kama mwezeshaji au mtoa huduma katika ngazi ya jamii nimefanya kazi zaidi ya miaka 7 sasa. Na nafanya kazi kwa jinsi hii. Wamasai ni watu wagumu sana kupokea kitu kipya, hasa kinapoletwa na mtu ambaye sio Masai, yani sio mtu anayemwamini. Wamasai wana tendency ya kuamini mila zao na kuamini watu wao. Kwa hivyo mimi kama Masai nimeshirikiana sana na viongozi wa mila, traditional leaders, na hao madaktari wa mila, loiboni wale, traditional healers. Mara ya kwanza tulifanya niliwahamasisha kwa kueleza matukio mbalimbali yaliyosababishwa na chanjo. Huko nyuma kuna milipuko iliyotokea mikubwa hasa ya surua na ikaua watoto wengi sana huko nyuma, miaka ya nyuma. Kwa hivyo tulichukulia kwa kueleza kwamba mnakumbuka kwamba miaka ya nyuma tulisikia magonjwa mengi ya milipuko yalitukia, ndio. Hivi karibuni mmesikia yale magonjwa, akasema hapana. Kwa nini haya magonjwa hayapo tena? Ni kwa sababu watoto wengi walipata nini? Walipata chanjo. Kwa hivyo hizi chanjo ni za muhimu. Kwa hivyo hata hii chanjo iliyoletwa ya COVID ni muhimu sana. Serikali kama serikali haiwezi kukubali kitu ambacho kinadhuru watu wake. Kama serikali imetuletea chanjo nzuri ya kuzuia surua na magonjwa mengine, hata hii tulioletwa na serikali ni nzuri. Kwa hivyo mimi kama mhamasishaji nilitoa elimu ile. Wale malaigwanani wakanikubali, lakini kingine zaidi mimi pia nilichanja. Kwa hivyo wakati natoa ile elimu naonyesha kadi yangu kwamba mimi kama mtoa huduma nimehamasika, nimechanja. Na baada ya kuchanja sikupata shida yoyote. Kwa hivyo wale malaiboni na malaigwanani walikubali na wao wakachanjwa. Kwa hivyo ikawa ni rahisi na wao, kila tunapoenda katika jamii au tunapita nyumba hadi nyumba, wanakuwa ni mashuhuda wazuri wa kwamba wao wenyewe wamechanja na hakuna madhara yote. Kama nilivyosema kwamba Wamasai tunaishi katika boma na wakati mwingine ni mbali sana na huduma. Mimi nashirikiana na watu wa huduma, manesi wa kituo changu cha afya, tunatembea nyumba kwa nyumba, huduma mkoba. Kipindi kile cha COVID kuna watoto wengi sana walibaki bila chanjo. Lakini pia Wamasai wanahama kutoka eneo moja kwenda eneo lingine kwa ajili ya kufuata malisho. Kwa hivyo wakati ule unakuta watoto hawapati chanjo. Kwa hivyo kwa kupitia huduma mkoba, mimi pamoja na watu wa huduma tunapopita nyumba hadi nyumba, tunahamasisha chanjo ya COVID, tunahamasisha chanjo hizi zingine, tunaitisha kwanza, hebu tunaomba tuone kadi ya mtoto. Anapotoa ile kadi ya mtoto, tunaona kwamba mtoto hajapata chanjo fulani au mwingine hana kadi kabisa. Kwa hivyo kwa kupitia pale mtoto anapata chanjo yake, wale walioko chini ya miaka 5, lakini watu wazima pia wanapata chanjo ya COVID, lakini pia wale wasichana ambao wamekuwa wanapata ile chanjo ya HPV. Kwa kweli kwa jinsi hiyo, kwa kweli tumeweza kuwafikia watu wengi, na kwa muda mfupi ambao tulipata, yani baada ya kupata support ya MCGL, tuliweza kufanya kazi kubwa sana. Kwa maana MCGL walituwezesha kwenda maeneo ya mbali. Ninapotolea huduma mimi nilikuwa naenda kilomita 21 kwa miguu kwenda kuhamasisha. Kilomita 21 kwa sababu mabome ya Masai yako very scattered, yako mbali sana. Kwa hivyo kwa kipindi kile tulikuwa nashindwa kwenda eneo la mbali, lakini baada ya kupata support ya MCGL tuliweza kufika maeneo mengi. Kwa maana tulikuwa natumia bodaboda, tunafikia maeneo yale. Hata sasa bado tunafanya kazi ile, na kazi ile kwa kweli tunafanya kwa ufanisi, na jamii yangu nashukuru kwamba wamenielewa na kwa kweli wanachanja kweli. Yaani tunapofika kuhamasisha wanatusikiliza na wanakubali kuchanja. Kwa hivyo kwa kifupi, hiyo ni kazi yangu ya kuelimisha, kuhamasisha, kushawishi, lakini pia kutambua watoto ambao hawakupata chanjo yoyote. Hiyo ndio kazi yangu kama mhamasishaji, nashirikiana na wenzangu, na kwa kweli mpaka MCGL ameniona ni kwamba kweli kuna kazi kubwa tulioifanya. Ni kazi kubwa. Mkifika pale Odonyosambu au Arusha DC kwa ujumla, utapata historia kwamba tumefanya kazi kubwa yenye impact kubwa ndani ya jamii. Na kwa kweli naendelea kushukuru. Nashukuru MCGL sana kwa maana kwa kweli wametuwezesha kufanya kazi. Isingekuwa wao, tusingefikia target ambayo ilikuwa inatakiwa. Ilikuwa katika level ilikuwa chini sana, lakini baada ya MCGL kutusapoti, kwa kweli tumeweza kufikia watu wengi sana. Nashukuru.
Asante sana David. Tunashukuru Mungu amekuwezesha, umekuja na mjini. Tushukuru USAID kwa rasilimali pesa. Na nafikiri kwa sababu tuko na Dr. Chawote hapa, tuanze tu kuhamasisha. Mheshimiwa Waziri jana alisema kuhusu ile training ya miezi 6. Naomba tusimsahau David basi, maana najua inakuja. So with that note, let's switch to English. Thank you very much to all our panelists. Now we have 10 minutes of Q&A, comments, reaction, anything you want to talk, and karibuni. So you can ask your question in whichever language you want, as long as it's not a local language. Masai, yes, you can, because David speaks Masai. Karibuni. Kuna kule nyuma. Na ukurugenzi. Please mention your name and try to be precise. Karibu.
Good evening.
Good evening.
Irene Stephen, an intern nurse, Muhimbili National Hospital. I have some questions and like recommendations. I will start with some recommendations. Recommendation, a question and recommendation. Any recommendation in ndani ya swali. You have somehow spoken on the eligible age ambao wanapaswa kupata HPV vaccine, kwamba tunajua ni mabinti wa miaka 14, lakini what if binti au mdada ana miaka 25 na hayuko sexual active, je, anaweza kapewa? Kwa wanaume pia wanaweza wakapata huyu virus. Je, kwa nini hii chanjo hatutoi kwa wanaume na tunatoa kwa wanawake tu? Kwa sababu na wanaume pia wanaweza wakapata hizo anogenital cancers as well as genital warts, though wanakuwa symptomatic. Kwa hiyo kwa nini wao hatuwapatii? Lakini kitu kingine kuhusiana na hii routine ya immunization kwa watoto, kwamba kitu ambacho mimi nimekiobserve kwamba kina mama wengi wana lack hii preconception care education, kwamba hii ikitolewa vizuri kwa ufasaha, kwa sababu hii ikitolewa anatakiwa mama kipindi mjamzito apewe hii elimu. Anapopewa hii elimu kipindi bado ni mjamzito, inakuwa ni rahisi hata akija kujifungua kuweza kuleta watoto wake kupata kupata chanjo. Make kuna mama
Asante sana nani, tunaomba wind up kwa sababu ya muda.
Okay. That the second. The third one ni kuhusiana na COVID-19, kwamba kuna research naona inaendelea pale inahusiana na kwamba mama akiwa mjamzito akiwa na COVID inawezekana ikapelekea mtoto kupata birth asphyxia. Kwa hiyo nimeona wanafanya like early stage. Sasa kwangu mimi ni swali nauliza, nalileta kwenu kwamba kwa nini msiweke like platform kwa mama wajawazito, kwa sababu hii birth asphyxia sasa hivi imekuwa kama tatizo, na wanasema inasemekana hii COVID-19 inasababisha, though bado hakuna results yet, kwa sababu kuna hiyo research ambayo inafanyika. Kwa hiyo
asante.
Nadhani nimeeleweka kiasi fulani.
Asante, umeiba nafasi ya watu wengine. Pasha. Naomba tumpe huyu. Nibakia dakika ngapi? 3. Okay. Just please be brief. Okay. One question. Tumpe mkurugenzi.
My name is Pascal Lucas from the University of Dodoma. A question to I think the person from Singida. Yeah, I've been in Singida for my clinical rotation at Singida Regional Referral Hospital. And my question goes directly to the involvement of youth during these campaigns. Like, we have medical students or we have medical personnel who are actually youth. I participated in one of the campaigns at Dr. Salmin, I think, secondary school or primary school. It's in Singida. But most of our healthcare providers who are involved in these campaigns, they don't actually give out the education which is needed by this youth. I remember when we visited that school, girls actually came in a large number in that room, but because of the education that we are just given over there, more than 50% got out of the room because they couldn't hear. And we told the mom, like, please, could you allow us to speak with them before you start giving them? She was like, tuna save muda. So there is this tendency of like, this generation, the old generation, they're not giving out the needed education.
For youth to learn.
Yes.
Tumekupata. Raimu amekusikia.
Yeah, thank you.
Asante sana. So wa mwisho, karibu Fatma. Dr. Fatma. Panelist mjiandae. Maswali ya kwanza magumu kidogo.
Ongezea tu, kuna na mengine. Umetaja dokta tu na hujamalizie. Mimi naitwa Dr. Fatma Kabole, nadhani nimetambulishwa mwanzo. Ya kwangu ni one is an addition and the other one is a challenge to timu yetu ya Zanzibar labda na wengine waliokuwepo hapa. Mimi nilipata bahati ya kuzunguka na Mheshimiwa Waziri wa Afya vituo vyote tulivyokuwa navyo. Hakuna hata kimoja ambacho sijapita. Nadhani kwetu sisi, this is the addition I want to make. We have the highest level of political will in the islands. And that has really helped to push not only chanjo, lakini other services. Mheshimiwa Waziri akienda anauliza, HPV hapa ni ngapi coverage? Anaambiwa target. Kule mwanzo walikuwa wanaanza gati. Tulipofika huku mwisho wote wanaimba. Anataja coverage ni ngapi, anazungumza target yake ni ngapi na vitu vingine. Kwa hiyo hili lilisaidia pia kuwaamsha watendaji wetu na wahudumu wetu kwamba level zote za juu za uongozi zina taarifa na zinafuatilia. Kwa hiyo ilisaidia sana. Lingine, I want to challenge the team. Kama ninavyosema, sisi ni visiwa. Tuna visiwa vingi tu ambavyo havina health facility. Wale watu kule hamwafiki. So that's the challenge to Abduli and your team, and we shall follow up. Ili tuweze kuwafikia watu ambao ni visiwani ndani ya visiwa. Wewe unajua, kwa mfano Uzi kuna visiwa vya pembeni. Huko wanaogopa kufika kwa sababu wanasema kuna wanga. Kwa hiyo nawaachia wao.
Asante sana daktari na mkurugenzi. Kwa hiyo naomba panelists, thank you very much for your comments. Just 1 second. Dr. Singida. Victorina, naomba ujibu swali lako la Singida nusu sekunde. Abdul utajiandaa kujibu yale maswali magumu nusu sekunde. Dr. Tinuboy yupo hapa atamalizia mengine. Nusu sekunde. No. Nusu sekunde daktari.
Asante dokta. Nashukuru kwa kupata hii concern. Kwa hiyo niseme nimelichukua kwa maana ya kuboresha in the future. Asante.
Thank you so much. Very much daktari. So Abdul, respond to the other questions. from nurse. Kuna 4 different questions, yeah? 25 years, and then issue of boys, and then vaccinating COVID during antenatal, and then also relationship with birth asphyxia and COVID-19.
Okay. Thank you very much, moderator.
1 second, eh?
I think these are the policy questions, some of them, so probably my director also will assist to answer, especially the issue of HPV, that we all know that boys also can be affected with HPV virus. And in some developed countries, they are providing immunization, HPV immunization to both girls and boys. But for Tanzania, actually when we started, there were a problem of supplies of the vaccine. And our target was to vaccinate 9 years to 14 years, but unfortunately, due to a lack of vaccine, we decided to stand with a single cohort of 14 years. And since we started, we are vaccinating 14 years only. But we all agree that boys are also eligible to be vaccinated HPV vaccine. But for sake of priorities and planning of the countries, the government of Tanzania has decided to prioritize the HPV vaccine for girls 9 to 14 years. But we all know that boys are also can be affected, and if maybe 1 day or 2 days, 1 day or in the coming years, the government can change the policy from vaccinating the girls only and go also to the boys. If the girls is 20 years and she is not sexual active, can be vaccinated with...
0 second, Abdul.
What?
0 second.
The policy, the policy of the United Republic of Tanzania is to vaccinate girls 9 to 14 years. And this policy has never been changed. So far, we are vaccinating 9 to 14 years girls for HPV vaccine. Thank you.
Thank you very much. So in addition to that, for 25 years, with WHO recommendation, you can vaccinate, but for Tanzania, we can't. And then we are taking your recommendation on the integration during pregnancy, providing COVID-19 vaccination. So with that note, big round of applause to our panelists. Thank you very, very much. And thank you very much for your active participation during late hours. We know that you're all tired. And thank you very much for our directors and big bosses for your opening remarks. May God bless you. But I also wanted to acknowledge the presence of IVD team. IVD team who are here, simameni basi. Our IVD family from Zanzibar, as well as Minister of Health Zanzibar and Tanzania both. Asanteni for kuja. And then also MCGL JHPEIGO staff who are here, JHPEIGO all. Thank you so much for coming. And everyone else, thank you very much. Our panelists, we love you. Let's give them multiple kisses. Mwah, mwah, mwah. Thank you very much. Communication manager, tunaomba group photo with the panelists na walio speakers in the opening remarks. Thank you very much. Nimefukuzwa jamani. Na mimi kwa majina naitwa Dr. Mary Rose Kawajiatas. Thank you for giving me opportunity to moderate. I'm married. I have 2 boys. Karibu. If you have a girl, you need to get a boy.